you know, the movement of the knee is in two degree of freedom. Flexion extension is 1 degree, and small internal external rotation is the other degree of freedom. All freedom of the knee movements is set up with the anatomy shape of the femoral condyles, and also this movement is restricted by the capsular ligament, capsule of the knee joint, and ligaments of the knee. Okay, if the movement exceeds the normal arc of natural movement, probably this will produce ligament strain or ligament tear. And we have to add another reason for trauma, because the knee joint is very loaded joint. All the weight of the body react in some movement which happens in sports, in trauma condition. That's why many forces will react over the structures over those soft tissue structures. And sometimes not only soft tissue could be involved in this injury, but also in bony structures like epicondyles, like eminentia intercondylica, and like condyles could be involved in injury. The mechanism of trauma usually is presented by varus or valgus stress applied over the affected knee joint. Additionally, exceeded rotation of the knee with fixed foot. Fixed foot means that this is a loaded limb at the time of injury. And then hyperflexion, hyperextension, but most often the injury mechanism is combination of the above mentioned mechanisms. This is not the only mechanism, because sometimes additionally a trauma could be produced in, for example, contact sports like football, volleyball, basketball. The other players could harm the region of the knee, and not only movements we can accuse about the injury, but also contact and additional force which is applied over the knee joint. What clinical signs we could expect in a patient with knee trauma? Usually a patient complains from appearance of sharp pain after the trauma or at the time of trauma. Sometimes patients report that feel the tear. He even hear the sound of tear. The joint became effused rapidly because of hemarthrosis, and pain and effusion will restrict significantly natural range of movement. Sometimes we could detect the formation of the joint, especially if there is a complete tear of some ligaments, or if there is additionally fracture around the knee. Those clinical signs are not enough to orientate the examiner. That's why in every case we need X-ray. X-rays should be done in two projection, AP and lateral. And in this way, we will be orientated about the presence or not of certain fracture. Okay, after we exclude a fracture, we have to immobilize the knee. It's good to apply some cold dressing for a few hours, and then we have to compensate the pain. After that, patients should be educated to walk with crutches, and we have to, in some cases with dislocation, for example, patella dislocation, we have to reduce the patella. In certain cases, we could find a special sign of locking a joint. This is not because of pain and not because of swelling, just the joint is locked because internal reason. This internal reason usually is torn meniscus, which stuck between the articular surfaces, and this reason make the joint looking like stiff, very stiff. In those cases, there is additional approach that we have to propose the patient, to advise the patient. We have to apply gentle external traction. Usually the joint is locked in slight or moderate flexion. We have to extend the knee gently, without pain, without forceful maneuvers, but we usually apply skeletal traction. After certain time, for example, minutes to hour, usually the joint is unlocked, and then we have to apply immobilization. It's not a good idea to immobilize the joint in locking position, because the consequences will be harmful to the joint. That's why first unlocking the joint and then immobilization. If the trauma happens previous day or long period ago, and we observe that the joint is swollen, there is hemarthrosis, it's good to perform puncture and to draw out the excessive blood or synovial fluid. This will help the patient to feel better, and this will help the joint to recover sooner. And additionally, this will help us with diagnosis because in the joint fluid, if there is a small drops of fat drops, this gives us information that probably there is a fracture, which is not recognized on X-ray. That's why puncture of the swollen joint is a good maneuver. It will help anyway. But we do not puncture the joint in acute phase after the trauma. We have to wait at least 24 hours. Because if we do that, there will be not so beneficial effect. After the puncture, usually we draw a big amount of fluid or blood, for example, 50 to 150 milliliters. It depends on many things, but after the puncture, we have to apply compressive dressing over the knee joint and then additionally immobilization. Anyway, the main diagnostic tool in knee joint trauma is X-ray. Clinical examination will give us some impression, but the X-ray will give us more information. Usually X-ray, 2 projection. Sometimes we could administrate stress X-rays. This will documentate joint laxity, which probably is a consequence from ligament tear. But in most of time, this will be painful to the patient. That's why it's not so applicable in acute trauma. MRI and CT scan are used in some patients with how to say, difficulties in diagnosis. But MRI is not the first diagnostic tool. Usually we make an X-ray, and when we have some doubt about meniscus tear, only in this case we will make an MRI, but not in the first 24 hours. Maybe in the first week after the pain is under control, and then we will complete our clinical picture with MRI. I said about the puncture of the joint, information, what we retrieve from this joint fluid. What is the treatment? In every case is different, but every painful joint, every traumatized joint should be mobilized. The most common period for immobilization is 20 days. Minor trauma could be mobilized for a less period of time, for a small period of time. But strain, ligament strain, joint effusion, contusion, or something like that, if this trauma is severe, the mobilization should be at least 20 days. Some of you maybe ask why 20 days? Why not more? Why not less? This is a decision which could be made after collection of all information about the uh, consequences of the trauma. It depends on how many structures are involved in the trauma. If there is a fracture or if there is any additional diseases, but 20 days is a one period which is not big, which is not small, and in the point of view of expected contracture, traumatic contracture, this period is ideal because after that we will start mobilization of the joint and the contracture will be easily avoided. When we faced with complete ligament tear in any of the ligaments of the joint, the best solution is to suture those ligaments in first 2 days, not more than 1 week. This decision should be taken with the emphasizing of the age of the patient, his profession or activity. Some patient has a high demanding activity like sportsmen, like young people. That's why the ligament should be kept natural if it is possible. That's why we suture torn ligaments. Meniscus tear could be very different. There are many of the ligament tear could be treated conservatively. Some of ligament tears could be treated by suturing of the torn meniscus to the capsule of the joint. Some of meniscus tear could be treated by arthroscopic removal of torn parts. That's why this decision could be taken after MRI examination. Bucket handle should be excised. This could be done both in arthroscopic way or in open way. I just saw one patient which we discharged 2 weeks ago with bucket handle lesion of medial meniscus. And he also had ACL rupture. This is a funny case, not so funny, but typical case. The patient explained me that he has visited a lot of hospitals, not less than 3, and everybody starts talking about the ACL reconstruction, but he could not walk without any additional support. And everybody starts talking about we have to reconstruct ACL. This will help you, something like that. But the most urgent problem for this patient was locked joint because of bucket handle lesion of his medial meniscus. That's why we operate him without talking about the ACL reconstruction. We excised the bucket handle, we unlocked the knee, and now he feels better. The decision about the ACL reconstruction could be done in any time in front, after a month or after 5, 6 months, next year, and sometime ACL could be left torn if the knee is felt stable. It depends on the patient activity. Okay, sense of instability, it's very specific because one patient could walk in even surface. One could practice some high energy sports, contact sports. Some patients report instability when they climb stairs or the other activities. For example, standing from a sitting position. It should be evaluated in a long period of time together with kinesiotherapist. In some patients, there is pain or there is no pain. Pain, in most cases, has pain usually stimulate appearance of joint instability because pain will cut off the motor signal from the from the brain. And if there is no enough muscle strain, the instability will increase and the sense of instability increases. That's why first we have to deal with pain, then we have to increase the muscle strength of the quadriceps, and then we have to evaluate the joint instability again. This is a long period of time. Sometimes it takes more than 2 or 3 weeks. And if the patient still experience some instability of the joint, then we will start talking about ligament reconstruction. If some ligaments are not healthy, not strong, and if they are not reconstructed, there is some space for post-traumatic osteoarthritis because movements of the joint will be changed, and the load of one compartment will be translated to the other compartment. That's why in a long period of view, probably this knee will be suffered from osteoarthritis. Treatment of ligament tears or ligament strain is non-operative. After the initial acute period, we apply immobilization, and then we start with recovering of the natural range of movement. Then we continue with exercises for the muscle, for increasement of muscle strength. In this period, probably patients will be supported by the orthosis, but all this should be observed by orthopedic and kinesiotherapist. When we decide to operate one ligament, first in acute phase, we have to suture the ligament, the torn ligament. In the chronic phase, the ligament could not be sutured. Complete tear usually leads to absorption of both parts of the ligament. And if we open the region after 1 month, we will not find anything to suture in this area. That's why we can do ligament reconstruction. We usually use a graft from tendon. The tendon has a little bit different characteristics, but it works very, very well for reconstruction of the ligaments. We sometimes use a bony tunnels at the point of insertion of ligament, and we conduct those grafts in the bony tunnels. After that, we tighten the graft, and then we fix the graft with different implants. Sometimes they are resorbable, sometimes they are artificial tight rope or neutralization screws. It's different in every operation. Traumatic joint contracture is a regular reaction of every traumatized joint. In acute phase, this is because of pain, swelling, hemarthrosis, but in chronic phase, this is the answer of immobilization. That's why immobilization should be done in physiological position. This physiological position is different for different joints, and it keeps the ligaments in the most strengthened position. In this way, physiological position of immobilization decrease the chance of contracture, of appearance of contracture. Contracture is actually limitation in normal range of movement. How we describe the contracture? When we say there is a flexion contracture of the knee or in certain different joint, we mean that the movement or normal range of movement is restricted and the patient could not extend fully his joint. It means it is in a flexion contracture, in a flexion position. When we say that there is extension contracture, it means that the patient could not flex fully his joint. It means, for example, the movements of the knee between 0 and 90, but normal range of movement is 0 to 130 and 140 in slim patient. That's why he has extension contracture. But sometimes there is a combined contracture, flexion extension contracture. If, for example, the movements are possible between 20 and 90 degree, this is combined flexion extension contracture of the knee joint. Abduction and adduction contractures are seen in different joints, For example, in hip joint, external, internal contraction, in rotation, also in the hip joint. But the knee, we could discuss only three types of contraction: flexion contraction, extension contraction, combined contraction. Do you have any questions about this till now? Are you familiar with valgus, varus, stress? When we check the collateral ligaments, we usually apply varus and valgus stress. And this is not the only. We have to compare the joint laxity in a healthy joint of this patient, because some patients has a natural joint laxity. And if he has additionally trauma in one of the knees, we could make a mistake with diagnosis. That's why every joint, every stress ligament, stress test of the ligament should be compared to the stress test of the healthy ligament in opposite side. Okay. What are the other reasons for a contracture? Probably pain. Pain could be presented in an acute phase, but pain could be presented in a chronic phase also. If there is osteoarthrosis, if there is additionally swelling, compressing, or inflammation, for example, around the knee, you know, there are a lot of vessels. For example, one case of phlebitis could produce pain around the knee, and the knee joint is completely healthy, but there will be contracture because of pain. Hydrops and hemarthrosis is obviously frequent reason of contracture. Deformation of articular surfaces is interarticular reason for contracture. This deformation could be as a consequence of trauma or as a consequence of degenerative arthritis of the knee joint. And this is frequently seen in our patients which come to the arthroplasty. They usually has a limitation of motion in the knee joint, and this is because of deformation. Not only because of deformation, but one of the reasons is that. The other reason could be contracture of joint capsule and some adhesions with the bony structures. This usually the joint capsule is not so elastic. And if it has some adhesions, this will produce contracture. Osteophytes also produce contracture, especially osteophytes in the posterior aspects of femoral condyles. Those osteophytes we usually excise at the time of arthroplasty, and in this way we will increase the flexion of the knee after the operation. In general, when we talk about the joint contracture, we know that there are a lot of reasons for joint contracture. There are interarticular reasons, There are extra-articular reasons, and we have to exclude one by another. In this way, we will reach a proper diagnosis of this condition, joint contracture. When we know the reason, we could solve the problem and we could cure the patient with joint contracture. I have to stop for a while. Excuse me, not more than 2 or 3 minutes. Okay, I'm online again. We continue with traumatic disorders in massive vessels and peripheral nerves. All of those are soft structures, and they have uh, their own patterns and consequences. That's why we have to know about them, to recognize them on time, and to treat them properly, sometimes together with the fracture. Mechanism of muscle trauma is usually overtension when the muscle work is hard, intensive, like in sports, like in some activity. Natural physiology of the muscle contracture, is not only change of the length of the muscle, but also hardening and squeezing the vessels which nourish the muscle. And when the cycle of flexion extension or working cycle is very fast and experience a big load, the perfusion of muscle will suffer. If the muscle cells are not well perfused, there will be collection of acid products. Those acid products will destroy the, the tissue, and this will be the reason for a muscle torn. Additionally, there is swelling, and some fibers will be torn, some other will be uh, swollen, and all this produce pain and loss of strength, loss of movement in certain muscle. The other mechanism is presented by direct impact or direct injury over the muscle belly. And this is usually because of contact or because of high energy trauma, which could produce fracture or which not. But anyway, the trauma agent, before coming to the bone, it passed through a muscle sleeve, and this will produce a muscle injury. Not only muscles, but also nerve and vessels will be lacerated or traumatized. That's why this is the other mechanism. Overtension, continuous work, and destruction of muscle fibers because of acid substances, and finally, direct injury. The location of disorder of muscles could be different. In every part of the muscle could be destroyed. One could be observed at the point of beginning of muscle. Then comes the point of insertion of the muscle to the bone. Then it comes transition between muscle and tendon, or at the part of tendon. Tendon could be ruptured. But sometimes we could see avulsion fracture because of strong muscular activity. That's why every part of this motor uh, motor system could be involved in the injury. Usually, the weak part is injured when the injury mechanism is working. But if the injury mechanism is strike or impact, the impacted structure is usually injured. Clinical signs of muscle injury. Usually, clinical picture is presented by sharp pain at the time of injury or at the time of happening of this destruction, weakness, swelling, deformation, hardening of the region, which is a consequence of hematoma or a consequence of muscular spasm. The movements are almost impossible and painful. The passive movements are also painful. In some regions, when we have a thin subcutaneous tissue, we could palpate a groove at the site of trauma. This groove is corresponding to the traumatized tissue. Usually, muscular fibers are retracted in opposite directions, and in their space appear groove. Joint contracture is obviously the most common feature. Okay, how we could, let me see for a while, treatment is separate. Okay, we continue with signs of traumatized nerves, peripheral nerves. Peripheral nerves usually comes or goes in different regions. Sometimes they are covered well with muscles, with soft tissue, with subcutaneous tissue, but sometimes they come in narrow spaces around the bony prominence, around the joints, and around the ligament structures, like in carpal tunnel in the carpal region. That's why it's completely different, the situation when happens trauma. In some cases, patient could experience pain after trauma of peripheral nerves, but sometimes not. In any way, in every case, there is a impairment of conduction of certain peripheral nerve. You know, peripheral nerves has sensory fibers, motor fibers, and also autonomical fibers. And the conduction, when there is a impairment of conduction, this impairment could be presented as paresis. The muscle which are innervated from this traumatized nerve usually do not work well or do not work at all. We could examine those muscle with a special scale of manual testing, which include 5 position from 5 to 1, I think, a active muscle movement, manual muscular testing. We also could observe hypoesthesia or anesthesia if there is severe trauma of peripheral nerve. But probably you know that the periphery of the skin is covered by overlapping of autonomical regions of certain nerves. It means that one region of the skin is usually innervated or is sensated by 2 or more nerves. That's why hypoesthesia and anesthesia, it's difficult to be examined, especially in the acute phase of trauma. There is a special term about this. Let me remember. Yes, they are described dermatomas. This is the region of the skin which is innervated from one nerve, dermatome. Okay. How about the traumatized vessels? You know, vessels are arteries, veins, and also lymph vessels. And according to the pressure, you know, veins and lymph vessels has a less pressure. That's why when the wall of the vessels is lacerated, there will be a small leakage in the soft tissues. But if the laceration involves the artery, it will produce a rapid growing hematoma, and the region will be painful, hard, and stiff. That's why this feature will give us beginning information about the caliber and the type of the vessel which is traumatized. Okay, if the trauma involves the major vessels, after the site of laceration, the peripheral pulse will disappear, and this is very informative for this trauma. We could feel the peripheral pulse only if the wall of this artery is healthy. If there is laceration, peripheral pulse disappear. It doesn't matter. There is probably there is a circulation, but there will not a peripheral pulse. And increased swelling is typical for artery laceration. Diagnosis is performed mainly by the physical examination in every soft tissue trauma. Sometimes we could use sonography, because sonography will detect very very well presence of hematoma, presence of swelling of some tissues in the deep, and that's why we use sonography. It's very fast diagnostic tool, but we have to educate it to use it. X-ray will not give us the same information. Soft tissue will be examined by sonography or MRI. Sonography is more accessible too. Some torn ligament and tendons also could be detected by sonography, but clinical signs are more objective. That's why we take information from both. Starting with treatment, every soft tissue trauma should be cooled by cold dressing and by immobilization at the beginning. If there is a laceration in tendon zone, this should be treated by surgery. We have to suture the ligament, we have to suture the muscle to the ligament, because if we don't do this, the gap will not be cured, and probably there will be fibrosis at the gap site, but this will increase the length of the motor the length of the muscle in general. That's why the function after the trauma, even after a long period of time and recovery, will be not the same. Muscles are very sensitive to the length. If we increase the length, the muscle strength will be decreased. Nerves. Nerves could be involved in 3 degrees. First degree is neuropraxy. Second degree is axonotmesis. It's not seeing this slide, excuse me. And third degree is neurotmesis. I will repeat. First degree, neuropraxy. Second degree, axonotmesis. It means that the axons are destroyed, but the sleeves are healthy. And third degree, complete, the nerve is completely divided, and it calls neurotmesis. First degree of trauma will be treated by immobilization, by giving a medication like vitamins B, Nivolin, and physiotherapy. Period of immobilization will last for 1 or 2 weeks, not more. Position of flexion of the joints will decrease the length of the neural structures. That's why it will help to recover. But how to detect what is the degree of trauma? This could be detected by MRI or EMG. EMG will detect the conduction of peripheral nerves. That's why this is a valuable tool for diagnostics. And if the case is fracture, at the time of operation of certain fracture, we could observe the condition of traumatized nerve. This is a very common condition when we deal with humerus fractures. In many of them, there is a traumatized radial nerve. And at the time of operation, we usually make a preparation of radial nerve. We usually keep the radial nerve in visual control, and we keep the nerve outside the bone or outside the implant which will be used. Only in this way we will preserve the nerve. But if we found the nerve traumatized or even lacerated, we have to suture the nerve, and this will give more chances for recovery of the patient. What it means, neurography? Neurography we do when the nerve is lacerated or cut or traumatized completely in third degree of trauma, neurodemesis. But we cannot suture a lacerated nerve. We have to suture a healthy ends of one nerve. That's why usually the nerve should be shortened. We excise the traumatized portion of the nerve, and we suture a healthy side to healthy side. This will shorten the length of the nerve. That's why we need to gain more length. In this way, we have to immobilize the adjacent joints to give us more length to the nerve. What does it mean, neurolysis? Neurolysis, it means that we perform debridement around the traumatized nerve, and we also incise the perineurium. In this way, the circulation around the nerve fibers will be increased, and this will help the recovery period. Transposition of the nerve we use, especially in cases around the elbow joint when there is a trauma of acute or chronic trauma of ulnar nerve. We have to change the position of the nerve. We usually take the nerve from the ulnar canal around the medial epicondyle, and we place the nerve in front of the elbow. We suture the tissue around the nerve in muscles. In this way, When there is a flexion of the elbow joint, there will be no additional stress to traumatized ulnar nerve. Is the most frequent use transposition of the nerve, ulnar nerve. Well, how about the vessels? Vessels also, patient with the vessel trauma also should be dressed with cool compressive dressing for the beginning. Sometimes there is a benefit of use of tourniquet in case of major vessels laceration when there is external bleeding. The tourniquet will save the patient life. There are a lot of examples of minor vessel laceration which lead to exitus because of improper treatment and long period of time. Even a small vessel which is left without care will produce significant blood loss according to the time. That's why compressive dressing, cold, and tourniquet will save the patient life. If we don't have a possibility for permanent stop of bleeding or permanent hemostasis. Vascular surgeons will help us to deal with some vascular trauma. But in case of small vessels, only compressive dressing will be the enough care for this case. What is important also in treatment of vascular trauma, this is the observation of the patient, the observation of condition of the limb, because compressive dressing will destroy the circulation of distal part of the limb. And this should be detected, prevented. That's why patients need observation by educated person. Control of blood loss. If it is necessary, there should be a blood transfusion or at least correction of volume of the circulated blood if there is significant blood loss. And finally, when the patient comes to the hospital or to the environment with a surgical environment, we could perform permanent hemostasis. Permanent hemostasis could be done by ligation of the lacerated vessels, or with vascular suture end to end. How it is cut, it should be sutured if it is possible. If there is a defect between both sides of the vessels, sometimes the vascular surgeons use a vein graft, which is taken from the healthy side or healthy region. Superficial veins should be used, or in sometimes they use prosthesis, artificial silicone prosthesis, which could uh, breach the gap between two parts of a lacerated vessel. Okay, the main thing, if I make a conclusion or a short advice, compressive dressing first, full observation of the patient, and then in proper environment, permanent hemostasis. When you apply a tourniquet, there are special protocol. The tourniquet should be applied only in two regions in the limbs. At the arm region and never at the forearm, in the lower leg, at the thigh region and never in the lower leg. Because when this part of the limb consists from two bones, the tourniquet will be not so efficient as in upper parts. That's why tourniquet should be placed only in the thigh or in the arm. Okay, the second is that you should notice the time of application, because sometimes patient will be transported to the hospital and the doctors or the medical staff have to know how long this limb is under tourniquet action. You have to record the actual time. This is the best way is to record this directly to the skin of the patient, because if you record this time on a piece of paper, this piece of paper could be lost. That's why you should record the time on the skin of the patient. And if the transportation is expected to be longer than 4 hours, or longer than 1 hour, I think this is wise to decrease the tourniquet, to release the tourniquet from time to time. Usually we do this in every 45 minutes. And then after a few minutes, we tighten the tourniquet again if the patient is not in the hospital. In this way, the perfusion of the limb will be spared for a long period of time if it is necessary. Okay, do you have questions till now? The answer of Marco is yes. Usually, strong muscle work will produce avulsion fracture. Most frequently in young patients. Okay. Other questions? The degree of trauma of what structure of peripheral nerves, for example, or what? Of nerves. Okay. First degree of trauma is neurotmesis. Sorry, excuse me. Neuropraxis. Neuropraxis. It means that the structures of the nerve are healthy, but the conduction is destroyed because of trauma. Everybody of you probably experienced neuropraxis. When you cross the legs for a long period of time, the conduction of fibular nerve is impaired. This is temporary impairment of conduction, and you feel a numbness of the foot and lower leg. Sometimes there is a foot drop even for a while, and this is neuropraxis. Usually, first degree of trauma of nerves cures, but it's by itself for different period of time. Sometimes for minutes, sometimes for a few days, but no longer than 3 months. Second degree is axonotmesis. Axonotmesis means that axons of peripheral nerves are divided, but the sleeves of those axons, the Schwann sleeves, are healthy. And the distal part of this axon will become necrotic. It happens valvular degeneration of the axons. And in the recovery period, there is advancement and growth of the axons from proximal part to distal part in the same sleeves of Schwann cells. The recovery period in second degree of trauma is usually 1 millimeter per day. If the laceration, or not laceration, but if the trauma site is more proximal, the recovery period will be longer. And the opposite, if the traumatized region is more distal, the recovery period will be more faster. But usually 1 millimeter per day. And finally, the third, the worst degree of trauma will produce complete tear of complete laceration of the nerve, not only axons, not only Schwann sleeves, not only vessels of the knees, but also perineurium is also involved. This will be not recovered without surgery. Okay, is it clear? Okay, nice. We continue with some clinical examples. Okay, actually, those clinical examples are not a consequence of trauma. Okay, we will finish in a few minutes, I think.
Sorry,
but very small, just 5 slides.
Yeah.
Okay. start eating your lunch. I will be fast. This patient has a vascular impairment, but not because of trauma, because of thrombosis. I put this slide to make a comparison between healthy limb and involved limb. The color is different, the temperature is different. If you see here, there is a necrosis of the toe. Then second picture present the surgical attempt to perform a vascular reperfusion of the arteries, and also fasciotomy. Fasciotomy decreases the tissue load, tissue pressure, and in this way will benefit the general perfusion of the limb. But it doesn't work in this case. And finally, we perform amputation of the thigh. This is because of vascular impairment, but not as a consequence of trauma. This is a consequence of general vascular disease, thrombosis. This is a special term, compartment syndrome. It's very important in orthopedics and traumatology, and this is the last thing I will talk for this session. I would like to strengthen your attention over this compartment syndrome. Compartment syndrome could be seen in limbs after trauma, and this is because of internal bleeding, sometimes with fracture, sometimes without fracture, but in any case there is a vascular laceration and internal bleeding. This internal bleeding, when is located in the closed fascial compartment, will increase the tissue pressure. But in this compartment, fascial compartment, there are a lot of soft tissue, muscles, other vessels, nerves, and all those soft tissue structures will suffer from the increased pressure. This increased pressure is presented for several hours, and this pressure will impede the blood perfusion in all distal part of the limb. It appears hypoxia, and if the reason of this hypoxia is not solved, the tissues will become necrotic. The first and the most sensitive tissue is actually nerves. Nerves are more sensitive to hypoxia. That's why the first symptoms in compartment syndrome comes from the nerves. If there is hypostasia or anesthesia in distal part of the limb, first thing we have to think for compartment syndrome. The second tissue which is very sensitive to hypoxia are muscles, but the muscles will react with necrosis. They are not so I don't know how to say. If at one time we deal successfully with compartment, for example, with elevation of the limb, or with the surgery by fasciotomy or something like that, the perfusion of the nerves will be established again, but even with the restoration of the muscle circulation of the blood in the muscles will become necrotic. That's why they are not so, how to say, if you understand me, I'm not sure. I missed the word, the proper word. So, okay, I will explain it again in different way and you will probably understand me. Okay, after that, in chronic phase of compartment syndrome, we could observe permanent contracture, because this permanent contracture comes with the growth of fibrotic tissue, which replace necrotic muscles. And fibrotic tissue has a quality to contract with time, with a few months. And this will form a permanent contracture of distal muscles. Okay, diagnosis. Diagnosis comes from the first and more sensitive structure, nerves. Numbness, paresthesia, or loss of sense. Usually, the distal part of the limb is more cold. Muscles are stiff. Muscles are hard, stiff muscles at a certain compartment. And we could detect also a weakness of the pulse, peripheral pulse, distal to the compartment, because this pressure will influence to the pulse. The best way to measure this is with ultrasound Doppler, and this should be recorded. Measuring of the tissue pressure could be possible with special tool by puncturing the muscle space, muscle compartment, and if at the end of this tube there is a tool for measuring, we could measure the actual pressure. If the pressure increased than 30 millimeters, probably there is a compartment syndrome, and after this 30 millimeters, it will rapidly grow and the perfusion will be discontinued completely. That's why 30 millimeter is borderline, and it's time for decision for fasciotomy. Treatment. The most important thing is to know about this complication, to look for it in every case with fracture, every case with soft tissue trauma, with edema, with rapid growing edema, and those patients deserve observation for several hours. Lying position, observation, elevation of the limb, if there is some signs of numbness or paresthesia. If it doesn't help to solve the sense problem, we have to check for the pressure of the compartment. We have to use ultrasound, and finally, we don't have to wait more than 6 hours after the beginning of this compartment. You have to do surgery, fasciotomy, and this will decrease the pressure of the compartment. Only in this way we will save the limb. If we miss to do this in a period of 6 hours, it will be late, and there will be a permanent destruction of affected muscles. And even if we do fasciotomy late, it is not possible to save muscles. After a few months, the treatment will be only debridement, excision of fibrotic muscles. They will be not a natural color, red. They will be gray. They will be white or gray. That's why we have to excise those necrotic muscles. After the excision, probably there will be improvement of contracture because this tissue is not active. This is not working muscles. And the excision is the only way to gain more movements, more range of movement of affected joints. And in some time, probably there is a need for muscle transposition. If we lose one movement, for example, movement of the fingers, of the thumb, or the extension of the wrist, it's better to perform a muscle transposition to regain these valuable movements. The principles of muscle transposition are very, very strict, and we don't have to destroy additional function. We only have to regain the lost function. Okay, I think this is the last slide for this session, and if you have some question, I can try to answer them. We cut the limb. We perform amputation only in severe cases when there is nothing to do, nothing else to do, and we have to save the patient's life. You mean amputation, Marco, or cut the limb? What do you mean? To perform fasciotomy or to perform amputation? Yes, amputation. No, in compartment syndrome, even in worst cases in compartment syndrome, we do not amputate. But the consequence of not well treated, not on time performed treatment is a very disappointed consequence, like Falkman contracture. Falkman contracture, it means that the affected muscles are ineffective and contracted. This will affect function of the hand or function of the foot. That's why we only excise the affected muscles. We do not amputate. Actually, after the acute phase of compartment syndrome, circulation will be established again. but the muscle stays necrotic even after restoration of the circulation. This is the problem. Okay, thank you, everybody. See you again at what time? At 4 o'clock, I think, in next session. Anyway, I will send you notification. Have a good lunch. You have few minutes. Bye.